this, so the CT scan looks very abnormal because the vessel systems are not properly seen, the sulci are obliterated, the ventricles are narrow. But now we measure the ICP is normal. That means you don't need to give a mannitol and dehydrate the patient and make him hypotensive. So this patient was just simply treated with a simple ventilation, normal ventilation, and he became alright. So like that, so there are different indications now for intracranial pressure monitoring. Any patient with head injury with a GCS of late 8 and less, and if the CT scan is abnormal, then it has to be measured ICP. If the glasocoma scale is more than 8, in certain situations, if the patient is very restless and needs sedation for ventilatory therapy, or if the patient has got extracranial surgery and has got a fluctuating GCS, then in such cases, even if the GCS is more than 8, then it's an indication for these are all Brain Trauma Foundation guidelines which we follow. The other thing which I like to tell about is the cervical spine injury with or without a head injury. When we see a patient with a head injury or a trauma, we always have a doubt whether he's got a fractured cervical spine, whether to do CT scan or X-ray, whether to give IV methylprednisolone. See, this is the lot of controversies still in this methylprednisolone, but now we have a definite guidelines, current guidelines, which I think we all of us should follow. So how do we suspect, when do we suspect a broken neck, a fractured cervical spine? All unconscious patients should be diagnosed to have a cervical spine injury until proved otherwise. Because it is impossible to clinically diagnose a cervical spine injury in an unconscious patient. In a conscious patient, the guidelines which you follow is what is called the Canadian C-spine rule. See, here, the conscious patient, if the patient is more than 65 years or there is a dangerous mechanism of accident, that is to fall from more than 5 stairs or more than 10 feet, high speed motor vehicle accident, ejection from a motor vehicle. In such cases, it means there is a high risk of cervical injury. These patients need investigations, and like that, the guidelines clearly tells when to do X-ray or CT scan in these patients. So briefly, if you find a patient is less than 65, he is fully conscious, he says no neck pain, he is able to turn the neck 40 degrees up and down, this way, side to side, and neurologically has no symptoms, then he does not need any X-ray or a CT scan of the neck. In all other patients, they have to do. Then the question is X-ray enough? Most often, yes, especially in individuals with a thin neck, long neck. Then we can see C7 to C1 to D1 in these patients, yes. But CT and X-ray can miss in 35%. So in such cases, we do multi-slice CT scan of the cervical spine with 2D reconstruction, which will not miss the bony injury. In very selected cases, when the CT is normal, but the patient has got a neurologic deficit, when we suspect a disc collapse and acute, then we do MRI. Now regarding IV methylprednisolone, if you ask the opinion of the most neurosurgeons or the orthopedic surgeons, spine surgeons, if you give high dose methylprednisolone in spinal cord injury, they will say yes. Because the trend has been set like that. But now there's a clear-cut Cochrane review that apart from the NASIP 3 study, there is no class 1 evidence to show it is beneficial to the patient. But there is enough evidence to show that it is potentially harmful to the patient in the form of infections. So right now, methylprednisolone is not recommended in patients with a spinal cord injury. Like that, now I gave us on head injury. Like that, we have in patients with back pain, neck pain, headache, epilepsy, stroke. There are so many guidelines. international guidelines which can be followed. Brain trauma finder guidelines, there are Canadian guidelines, American Academy of Neurology. We use American Heart Association cardiologist lung guidelines also for the stroke patients. And in India, we have only guidelines for epilepsy. The guidelines for epilepsy management in India, the GEMIND is only probably in neurology, neurosurgery, where there's an Indian guidelines available. In most other things, they are still, even the GEMIND is more, they have adopted the International League Against Epilepsy guidelines. They have brought it with little modifications. Like that, we follow mostly Brain Trauma Foundation guidelines with a little modifications to suit our country. That's what we follow, what I told earlier. The most important thing is, can I continue or?
Continue.
Because I mean, so the other things, the guidelines, it definitely helps to minimize errors in clinical practice. And we have what is called the red flag signs. Red flag signs, which, for example, a patient with acute headache, whether to investigate this patient's CT, whether to just give them, we have definite guidelines. With the red flag signs, the patients with vomiting, severe intensity, and then any patient who gets a pain at night which wakes up the patient with altered sensorium, the patient's got a neck stiffness or a minimal deficit, then we take it as a red flag sign and we investigate. See, one example I'll give, one male had history of chronic headache, and one sudden morning he had severe headache. While sleeping he vomited, he was unconscious for a few minutes but he woke up. Next day morning he was having headache. He consulted a family physician. He was prescribed mefenamic acid and some antidepressants because he used to come with headaches quite frequently. But 2 days later the patient again had severe headache and became unconscious for more than 4 hours. Yes, these patients clearly is something different from the routine migraine or whatever chronic headache he had earlier. So CT scan showed subarachnoid hemorrhage, and so the angiogram showed the complex intercommunicating artery aneurysm. So it was operated, it was clipped, and this is the post-op angiogram where the testing done, and he did well. So it becomes, see, the problem was the guideline was not followed when the patient presented with acute headache because the neck stiffness was not good for. So that's such things. I mean, if you follow the guidelines strictly, then we don't do such things. Like that, we have guidelines for headache and guidelines for seizures, when to suspect a brain tumor, any late onset focal fits, changing pattern, long post-ictal palsy means probably it is a tumor and one has to do that. So there is so also in back pain, when a patient has got a pain at night and it is persists in lying position, non-weight bearing, wakes up the patient from sleep or has got minimal numbness or weakness, then we suspect malignancy or infection. So these are the red flag signs. These patients need investigations. But in practice, what we find is most patients with back pain, they go in for MRI immediately. The first few days itself, it is not the recommendation. As per our guidance, it is not recommended. The most important thing is when a patient comes with the back pain, we exclude malignancy and we exclude say KV spine, and if it is a discogenic pain, then we don't do MRI. Because sometimes MRI can be very misleading. See, if this patient had a back pain and MRI was reported as normal, but you say a standing X-ray shows there is an instability. So MRI can miss things. It is not the final answer. And sometimes if the patient is not properly examined, the patient comes with lower limb, some numbness, and only lumbar MRI is done, And you find that clinically, if you see this got a upgoing plantar, and if you do later higher up, you find there is a meningioma. So these are the small easy things which we can be diagnosed, it can be corrected. So the guidelines for MRI in back pain is it is not indicated for 4 weeks in the discogenic back pain. That means clinically we should be able to differentiate whether it's a discogenic back pain or not. That means a discogenic back pain characteristically it is less in the lying position, either right lateral, left lateral, the pain subsides. It is not there at night unless he turns this way. So like that, now we have got different ways of diagnosing discogenic back pain. So in such cases, MRI is not indicated for 4 weeks. But of course, if there is a significant neurologic deficit like a bladder involvement, foot drop, they got a proximal muscle weakness, then we do it. Of course, quite often we are forced to do because the patient himself wants that, he wants to have MRI done, then of course we are forced to do. Then so these are the guidelines which we follow. Of course, there is no substitute for the detailed clinical goal-oriented examination, which is very interesting and rewarding. It is a like detective. We ask the patients so many questions one after another, and then we find out what's the pathology and where is the pathology. Then so we do some interesting, simple screening tests. So most of the tests we do, as we say, we make the patient walk and ask them for arm drift, finger grip, finger spanning. I'll just show some, and then we make the patient toe walking, heel walking, tandem walking, hopping with either leg, foot tapping. These are the simple screening tests which we do to diagnose subtle neurological deficits. See, this patient, it looks as if he is walking normal and he doesn't have any neurological deficit. But you see, you ask the patient to tap, foot tapping. If you do that, then you ask him to do it on the right side. You can see he's not able to do properly. That means he has got a right foot weakness. So like that, now you see this is alternate movements of the left hand is normal, but you see the right hand, it is no independent movement. The whole limb moves. It's a pyramidal sign. So you know he has got a definite left hemispheric disturbance. Because in practice, good judgment is supposed to come out of experience, but experience itself comes out of lessons from mistakes. And we should see that we don't repeat mistakes. We can make new mistakes. And at the end, I would like to say to be a good general practitioner is several times more difficult than being a good super specialist. Again, at the end, I would like to say that we have evidence, we have expertise. We form guidelines, and the guidelines are followed again. We evaluate the current practice, the results, and then it goes back to evidence, expertise, and we form a patient, we form an integrated clinical decision in any given patient. Thank you.
Next, please. Any questions?